Hi, I'm Dr. Jennifer V. Brown, your stroke specialist. And today we're going to discuss treatment options for stiff knee gait after stroke. Before you can provide treatment, you have to measure what the problem could possibly be causing the stiff knee gait. And the first thing I want to turn your attention to is contracture. Is it at the ankle joint? The ankle joint contracture will cause what we call closed chain plantar flexion. The leg or tibia bone will be angled behind or posterior to the ankle joint. You should measure that with the knee bent and straight, laying down, sitting, and standing. And then I want you all to measure volitional control. How does the movement occur in the lower extremity and does it change from different positions? Just because you can move your foot, ankle, knee, hip, anti gravity, isolated, great movement, as soon as you become vertical and you're standing, you lose that ability. And that has a lot to do with the damage to the corticospinal tract, the lateral portion going to the lower extremity, and then other descending motor tracts having to take over. Let's look at the video. As you can see on her back, she has nice hip and knee flexion movement. That ankle drops a little bit below the knee, so she's bending the knee, and her foot is not pointed down and away from her. She's bringing her foot relatively. Now let's look at it when she's standing and what the movement looks like when she's walking. So now you see she's not getting all of that hip and knee flexion. And to clear her foot, she is swinging her leg out to the side. And if you noticed, her toes are still dragging the ground and they're not parallel to the floor in neutral ankle dorsiflexion. So, what is it that I want you to do in terms of treatment? I want you to spend a lot of time in kneeling. But if there is ankle tightness or knee tightness caused by muscles and not contracture, you can do mobilizations to increase the musculotendinous and the ligament flexibility across that joint. So I do hand mobilizations where I'm applying an external force to the talocrural joint, as in this picture, and I have the person scoop forwards, backwards, side to side, or in this video, I use a door stopper at the hind foot and I move forward in the chair, backwards in the chair. I come up to squat and I hold that position to load the leg. I have a previous video that shows where to place the door stopper to increase mobility at the talocrural joint, the hind foot, and the midfoot, as well as the forefoot. If you want detailed explanations, you can go to an article I wrote for LER, Lower Extremity Review magazine, and I do believe it is in the April issue, or it may be the March, in which I talk about mobilizations using the force of the body weight to increase ankle mobility and portions of the foot. Activities-based therapy should include closed chain flexion movements, flexion at the hip, flexion at the knee, dorsiflexion at the ankle. And you've seen some of these pictures before. They're so important But very rarely do physical therapists spend time with people in these weight bearing closed chain activities. High kneeling. If you can't do it on the floor, do it in the chair. Have the person reach above head, left to right, backwards, out to the side. You get so much flexibility in strengthening. While in high kneeling, be it on the floor or in a chair, use some PNF stabilization patterns, rhythmic stabilization, alternating isometrics. Hold, relax, active movement from low kneel to high kneel to build strength in your glutes, your hip flexors, your hamstrings, and your quads. When doing half kneeling, always keep the hemiplegic leg in a bent position by putting it in front and going down and back with the less affected or the stronger leg. And then you have to weight shift on that leg, and you may need some help. But because the leg is already bent, it should be easier to move posteriorly or behind you and get it into high kneeling. Once into high kneeling, practice going down and putting the buttocks on the heels. Stay there for a minute. Move the trunk forwards, backwards, side to side. Practice reaching across the body in a diagonal. Practice reaching backwards and looking behind you. Practice reaching forward and across to the other side. Rotation in low kneeling and high kneeling is very good to engage the lower abdominal wall and helps to maintain pelvic stability, especially when you reach sideways in this frontal plane. Don't forget to do step over step stair negotiation and curb negotiations. If you're not outside, use a step or blocks or books inside the home and step down forwards, step down backwards, and step down sideways. All of these things load the knee. Make sure you're stepping down forwards, backwards, and sideways with the less affected leg first. Remember, I'm your trusted source for all things stroke neurorehabilitation and ankle foot orthoses. If you're enjoying these videos, please share them. They're uploaded every Tuesday and Thursday. And don't forget your references. We have to use evidence-based practice that we can analyze for the appropriate information and apply it to our patient population. Thank you so much for watching the video. See you next time. Bye-bye.